Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, welcome to Clinical Clips. I'm Dr. Ioana Preston, and I'm Associate Professor of Medicine at Tufts University School of Medicine. In this second episode, we'll be reviewing exciting data presented at the CHEST Conference 2024 from October 8 and October 9. During the Harvard Heartbeats session, a very interesting report looked at addressing pulmonary hypertension quality of life and survival. The study looked at patients enrolled in two long-term registries, OPUS and Orpheus. And patients with pulmonary arterial hypertension were enrolled in these studies if they were treated with macitentan. A large population, real-world data showed that the African American race was represented in 16% of this population. The treatment patterns and the demographics were recorded. And the conclusions were that Black and African American patients tended to be younger, were more often female, and with a higher incidence of connective tissue disease-associated PAH, and a greater comorbidity burden than white patients. For those with data, Black African American patients had more functional impairment at initiation of treatment than white patients. However, the hemodynamics were very similar between white and Black patients. Overall treatment patterns, safety, tolerability, and survival outcomes with macitentan treatment were similar. However, all-cause hospitalization was higher in Black African American patients. The next interesting report was the expert consensus on the definition of methamphetamine-related pulmonary arterial hypertension and associated treatment considerations. This study was a Delphi consensus opinion that was drafted by experts in pulmonary arterial hypertension with the specialty in meth-treated patients. And they achieved consensus in many aspects, such as the disease course, that in methamphetamine-associated PAH, the disease is more severe at presentation, and the morbidity and mortality in 1 year is much higher than other forms of pulmonary arterial hypertension. Hence, the prognosis of the patient is much more poor. The patients are in need for more social support, and there are issues that are more frequent as regards with compliance of medications. The consensus statement suggested that patients with methamphetamine-associated PAH should be included in clinical trials that discover new treatments for pulmonary arterial hypertension, and that they have to have a more focused care with support regarding medication tolerability and adherence to the treatment. The next poster that I found very interesting looked at national trends and inpatient outcomes in patients with pulmonary hypertension. This was a very large study that looked at patients who are hospitalized with a diagnosis of pulmonary hypertension. And it analyzed national trends and inpatient outcomes for PH in patients in the United States between 2016 and 2020. They found that females accounted for slightly over 50% of hospitalized PH patients, and their average age was around 70. Age was a significant risk factor with mortality worsening by 1.2% per additional year of age. There were racial disparities that were noted. Hispanics and Asians had higher odds of mortality compared with whites, while Blacks showed a 4.8% lower mortality risk. In general, females had a lower mortality risk than males. So the authors suggested that pulmonary hypertension places a significant burden on healthcare systems, and that disparities in mortality risk highlight the need for targeted interventions to improve care across different racial and ethnic groups. A very interesting session called What's New in Pulmonary Vascular Disease? Updates from the 7th World Symposium for Pulmonary Hypertension. The speakers went through the new definition, risk stratification, and treatment algorithm that I would like to highlight for you today. Regarding the definition, the hemodynamic definition with a mean PA pressure over 20 millimeters of mercury and a pulmonary vascular resistance over 2 Woods units is here to stay. And regarding classification, there were certain modifications in the classification among the 5 groups of pulmonary hypertension. There was an introduction of long-term calcium channel blocker responders to highlight the importance of following these patients long-term to make sure they maintain the response to calcium channel blockers. And another difference compared to the previous classification was in pulmonary hypertension associated with lung disease, where the prior classification broke down the subgroups into restrictive, obstructive, or mixed disease. The current classification recommends breaking down into disease categories. In other words, pulmonary hypertension associated with interstitial lung disease, or pulmonary hypertension associated with COPD and emphysema, or pulmonary hypertension associated with a combined pulmonary fibrosis and emphysema. Regarding the assessment of patients' severity of the disease, we now have several risk scores. The French risk score, the Reveal 2.0 and Light 2 risk score based on the US databases, the Compara risk score, and the Swedish risk score. What is important is that the symposium recommends to clinicians to apply a risk score that is useful and easier for their clinical practice, but to follow these risk scores. And then lastly, the risk scores have a tremendous advantage, but they have also shortcomings, and they tell us that patients still have a poor survival at 3 and 5 years, despite of medical therapies that we have currently available. And lastly, the treatment algorithm that was proposed had significant changes compared to prior years. Now the treatment algorithm is focused on pulmonary arterial hypertension, and patients who have comorbidities need to be taken into account, but they highlight the fact that only if there are significant comorbidities, these patients need to be reevaluated to make sure they are in group 1 and they don't have an overlap with other PAH groups. But regarding group 1 PAH treatment, the initial assessment is whether the patient is high risk or not high risk. So the low, intermediate risk are grouped together, and the recommendation is to start with dual oral therapy with a PDE5 inhibitor and then an endothelin receptor antagonist, whereas patients in high risk are recommended to be started with 3 therapies, including an intravenous or subcutaneous prostacyclin. The other important difference is at follow-up, patients who are not in a low risk score are recommended additional therapy that can be in the form of an oral or an inhaled prostacyclin analog, a switch from the PD5 to a soluble guanylate cyclase stimulator such as riociguat. But more novel is the introduction to treatment of the activin signaling inhibitor sotatercept that has been recently approved in the US and Europe to have as an additional treatment for patients who are not in low risk. So very important message to try to achieve a low risk status and use combination therapies. Follow patients very closely because we do have opportunities to impact the disease with the therapies that we have available. The next interesting poster looked at hemodynamic effects of midodrine in pulmonary arterial hypertension in patients who were hospitalized for different reasons. This is a study from a Methodist hospital in Houston and looked at a large population of patients with pulmonary arterial hypertension and compared those who received midodrine versus those who didn't receive midodrine during their hospitalization. The key findings show and suggest that midodrine helped maintain and stabilize the mean arterial pressure and supported uptitration of pulmonary arterial hypertension therapies. Hemodynamic parameters remained stable with no significant adverse events with the use of midodrine. So the authors concluded that midodrine can be effectively integrated into the PAH treatment regimen when patients are not stable to support the systemic blood pressure without negatively impacting hemodynamic parameters in the pulmonary vasculature. The last poster that I would like to mention to you is the poster that looked at pulmonary vascular resistance and lung transplantation in the UNOS-based analysis for 1 year survival, free of death or retransplantation. So we know that higher pulmonary vascular resistance is associated with poor post-lung transplantation outcomes, but the relationship between PVR and 1 year survival remains still unclear. This particular study looked at the UNOS database for lung transplantation to assess survival and retransplantation rates at 1 year. The review looked at over 34,000 lung transplants from the UNOS data between 2000 and 2023, and variables included recipient and donor characteristics, PVR, single versus dual lung transplantation, and ECMO needs. This analysis showed that higher PVR with a tertile of a PVR over 3.8 Wood units was associated with worse outcomes. There were increased rates of retransplantation and death at 1 year, and patients in this tertile had longer ischemic times, higher ECMO needs, and more post-transplant complications. Kaplan-Meier survival analysis showed worse survival in the highest PVR tertile, and the adjusted Cox regression modeling indicated a high risk of death and retransplantation for patients in the highest PVR tertile, with a hazard ratio of 1.1. So in conclusion, among lung transplant recipients, those with highest PVR tertile had significantly higher risk of death or retransplantation at 1 year. Thank you so much for joining me today. To download the slides and access other related topics, please return to the landing page. Thank you.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.